All right, so we are going to kick off our second session with a couple of pro-con debates. Our first one is going to be with Drs. Rob Bryant, Scott Wieters. They're going to talk about balanced fluids and non-balanced.
All right. Thank you. So my name's Rob Bryant. I'm from New Zealand, so I always sound like this. It's not an AV issue. The Australians will understand me. The rest of you, they can translate if you need them to. So Scott and I are going to be discussing the merits of saline versus LR. Since I'm from the true South, the deep South, I chivalrously am going to let Scott kick it off first. We have no conflicts of interest to declare. Scott Wieters is arguing the side of LR, and I will be taking over after that.
One moment. Thanks, Rob. You do have one conflict of interest that I think we need to disclose. Your sponsorship by Salt for your full-body onesie must be recognized and denoted. This is not an objective talk from your end, so I just want to make sure we're clear. I mean, we've been drowning in salt water since the 1800s when people were dying of cholera. And back then, we didn't really know what our plasma was. Is it acidic? Is it basic? Is it salty? Is it not? What's in it? We don't know. So some brave people mixed up some salt and some water. They sterilized it, they used it, and it worked. And another 150 years later, we're still doing the same thing. No one's really raising the question, should we be using sterile salt water to resuscitate people? We've just kind of always done it the same way. And that just really, I think, sticks in the side of our evidence-based approach. So I can't say that saline is normal. I think we have to agree that in comparison to our body fluids, we are giving people an abnormal saline solution. And the acronym that I would like to use is that your ass is not normal, Rob. Okay, so let's just get that straight when we talk about nomenclature here. Now, my first point is that your ass is not normal. Let's look at the composition of saline. And let's really do a deeper dive beyond the 1800s and take a look at what we're dealing with. So looking over here at our plasma, you can see that we have normal levels of sodium. We've got potassium, chloride, calcium, magnesium, bicarbonate. Our normal plasma is quite complex. The abnormal salt solution that we're using is not that complex. Again, we're seeing high levels of sodium. We're seeing high levels of chloride. We're missing so many vital components. So in order to call this normal saline, I think we're being a little bit disingenuous. Now, Ringer's lactate, plasma light have important things, like a little touch of potassium, some calcium, magnesium, and it's buffered a little bit. So again, my first slide is that it's not normal. And second, for your abnormal salt solution, Rob, your ass is a tad acidic. Now, let's look at some common things, okay? All the beer you drank last night, Rob, 4.5. I saw you take down 3 cups of coffee. I know what you're drinking. Of course, our normal pH is very sensitive. When's the last time you had a nurse say, Dr. Bryant, quick, come. Someone's dying of alkalosis. Let's save them. I mean, these things don't happen. Everybody goes through this spiral downward effect of acidosis upon the last few moments of life. And so if we're using abnormal salt solutions that are acidic with a pH of about 5.6, why in the world are we encouraging death by using abnormal salt solutions? We must ask these important questions. And I plan on a good rebuttal from you upon this firm point. So your ass, it's acidic. The next point about your abnormal salt solution, Dr. Bryant, is that it is quite inflammatory. We know from models in rats and your beloved favored companion animals, the sheep. I'm not sure why that's funny, but apparently that's a big deal. Animal models have shown that inflammatory markers, cytokines, interleukins, cascades of inflammation occur in all organ systems when you give abnormal saline to animal models. Okay, now we're starting to see this in human models. We're starting to look at this a little bit better beyond the days of cholera. And we're starting to see that when we do this, we're seeing inflammatory markers bump up in humans as well. The most important thing, and the most important organ I think is most well appreciated and studied, is that the abnormal salt solution is harmful to our kidneys. So Rob, your ass is quite offensive and harms kidneys. Not so good. Yeah, I mean, if we look at some of the bigger studies that have been done recently, the major adverse kidney events, we're looking at renal replacement by dialysis, we're looking at kidney failure by increased creatinine as being offensive from this abnormal salt solution. And this is data that's going to be tough to rebuff because it really looks like high levels of abnormal saline are harmful to our kidneys. Especially when we talk about sepsis. And I don't know about you guys, wherever you practice, whether it's Australia or whether it's here in South Texas, up in North Texas in a place called Canada, wherever you practice, you're going to see some sepsis. And so if you're giving this abnormal salt solution to people with sepsis, I'm sorry, but you ain't doing them no favors, because that's really where things are harmful. So the last point about your abnormal salt solution, Rob, your ass ain't superior. The call today, the debate today, the journal articles of today, the challenging philosophical arguments of today are, is lactated ringers or plasmolyte balanced solutions, are they superior to normal saline? No one is trying to make the ridiculous, audacious attempt to say, is saline superior to balanced solutions? Just like the poor argument you're about to make, people are holding on to that fine hope that saline is even equivalent. And that's a very tough argument that you're about to make. So, my take-home point is, if you think that normal saline is normal, you're an ass. Should I open it now?
I think that asking the entire House of Medicine to wholesale change to lactated ringers is just silly. Scott, what you need to do today is convince a simple sheep herder like myself to go back to my home institution and be an opinion leader and convince everyone else in that institution to change to lactated ringers. And I want to set the stage for just how stupid I am so you understand the Herculean task that Scott has to achieve. Regularly, dumb things come out of my mouth. Anyone that knows me will vouch that I'm not smart. Midway through residency, middle of the night shift, something especially stupid came out of my mouth, and one of my attendings loudly proclaimed to the entire emergency department, including patients, right now, somewhere in New Zealand, a village is still out looking for their missing idiot. I am that missing idiot. At this conference last year, when Haney Malamet erroneously told me that Scott was not only a fan of Christ, but actually a minister with his own congregation, it's believable. He's got the preacher's jargon. I thought the next best thing that I should do is to go up to Scott and tell him a joke about Jesus and tetanus shots. On that note, Scott, prepare to get crucified. Scott spent a lot of time talking about his ass or my ass or asses in general. So let's explore that a little more. Scott, your descendants, when they moved here in the 1800s from somewhere probably not sunny, would be horrified at your diction. It's not ass, it's an arse, which leads us to my acronym of the day. Always rely on saline. Every time, you'll be just fine. Scott made the point that LR is better than saline because science. Inflammation and acidosis and all that stuff that will help you do really well on your step 1 exam. If I believe you and try to take that to the bedside where the rubber meets the road, I'm going to be met with a little bit of resistance. This is Jay. He's one of my charge nurses at my big hospital. Jay is actually friendlier than he looks in this picture, but he doesn't like surprises. He doesn't like change, and there are some shifts where he doesn't like me. On Tuesday morning, I turn up to work, and I say, hey, Jay, I got this patient. He's 60. Most of his vitals are 80. He's got pneumonia. He's hypertensive. Can we give him a half gallon of lactated ringers, a gram of Versephin, and then some azithromycin? Jay is going to say, are you kidding me? In biblical terms, Scott, he's going to tell me to go forth and multiply. Jay's going to say, Rob, you're crazy. Don't you know that Rocephin kills babies when it's mixed with lactated ringers? There's an element of truth to that. The lactated ringers can combine with the calcium in the lactated ringers can combine with the Rocephin and make a salt that will cling to the lungs and the kidneys of babies. And in theory, Scott, that's a great way to prevent them from getting pyelonephritis and pneumonia, but it doesn't work that way. So yes, LR and Rocephin can be dangerous, and there's a warning that we shouldn't do that in our adult patients. There's also a dozen other medications that have either actual contraindications or relative contraindications. Rocephin. My beloved ketamine is on that list. Zosyn, Chris's TXA. My nurses don't like it, and it is a pain in Jay's arse when I ask them to do things that don't compete well together and that are not compatible together. So it's hard, even if I believe in all of your step one science, it's going to be hard for me to convince my nurses to take that to the bedside. Scott hinted at the SALT-AD trial. The authors of this study had multiple patient-oriented outcomes to consider. They had the option of looking at hospital-free days, acute kidney injury, renal replacement therapy, or death. They chose hospital-free days. The primary outcome of that study, which it was powered for, was negative. Yes, so there was a little bit of kidney injury. There was a little bit of increase in creatinine at 30 days. But the important outcome for my patients, did you die, wasn't met. Scott pointed out that the SMART trial showed uncharacteristically different results than all of the other crystalloid trials, including a significant change in mortality. And he points out that LR is better than saline because of that SMART trial. Your theory that it's all because of the kidneys has a few holes in it. Within the SMART trial, there were a couple of graphs of your chloride level and your bicarb level. Buried deep in the appendices of this study was the creatinine graph. Surely, if you're healthy hospitalist patients that had that bump in their creatinine, when we take a sicker ICU-based population and look at their creatinine, shouldn't we see a spectacular change in their creatinine? And shouldn't that graph be in the main part of the article rather than buried in the appendices? There's no change in the creatinine. You point out that there was this mysterious difference in death seen only in the SMART trial and not in any of the other trials. There's one trial that showed the spectacular difference that you're asking me to change my practice on. It's a little reminiscent of something that happened in the 90s when the NINS trial made us change our practice and none of the other trials changed anything. I would like to see more trials showing that big difference before I have to interact with Jay and ask him to do something that he doesn't want to do. If I was to design a perfect crystalloid trial, I would go to an idyllic South Pacific nation where the women are strong, the men are handsome, and the children are all above average. The Lake Wobegon of the South Pacific. I would be pragmatic. I'd take all ICU patients coming from wherever in the hospital they ended up in the ICU. I'd have them on saline or plasmolite, which is pretty close to LR, and I'd look for actual patient-oriented outcomes of acute kidney injury, renal replacement therapy, or death. I'd call it the SPLIT trial. And I'd publish it in 2016, and I'd find there is no difference at all. Maybe it's because New Zealanders are significantly tougher than Americans, and they've got better kidneys, or maybe because there's no difference. One thing I've learned from the recent news cycles is that as a member of a foreign nation, if I want to take out an American, I'm going to need help from another foreign country. I asked the Chinese for some help. This meta-analysis of 20,000 patients looking at important patient-oriented outcomes of renal replacement therapy, acute kidney injury, death, and hospital length of stay, no difference. Scott, I want to spend just a little time focusing on my ass now, and I know you have been spending most of the time focusing on my ass. If the hospital was a bird cage, the emergency department would be the newspaper on the bottom of that bird cage. Nobody upstairs cares what I do with my ass downstairs. I work in a hyper-efficient system where my ICU patients can be in the ICU within 3 hours, sometimes within an hour and a half of hitting the door of the emergency department. They come in, they're super sick, we resuscitate them, and then they get upstairs. No one upstairs cares what I do with my ass downstairs, and if I'm giving less than half a gallon of fluid, that's less than 2 liters, Chris. then no one upstairs is going to care what I do. The SALT-ED trial shows that there's no split in your precious creatinine within those first few hours. I don't know about your system, but in my hyper-efficient system, sticking with saline is going to get me where I need to go, and it's going to keep Jay off of my back, and I'm not going to make my nurses angry, which is a priority for me when I'm at work. Final point on the conflict of interest issue. You notice Scott's carefully coiffed hair that he has to manage twice a day. He has a significant amount of crimson follicular fortitude that he has to deal with several times per day. No simple hair gel will work for him. He needs a saline-based gel to control that hair, and I think he is diverting saline by trying to make us switch to LR so there's more saline available for his hairdo. Salim is very clever, and I always agree with everything he says. At this point in time, it appears if you're using saline or balanced crystalloids as your resuscitated fluid of choice, keep using your fluid of choice. Always rely on saline every time.
Let's see if I can put this on properly here.
It's a nice ass.
How's it look?
Dumpy.
First of all, that was a horrible British accent. Horrible. And to say that you should use something every time or always or some of these extreme recommendations, I mean, it really insults the knowledge of our audience today. You were all trained as professionals. These are drugs. And we need to know when to give the drug and when not to give the drug. So no, I don't think you should use saline every time. I'm not going to use saline in neonates. I'm not going to use it in people that I feel have, I'm not going to use lactated ringers in neonates. I'm not going to use that in people with head injuries, or I'm worried about maybe a sodium channel blocker overdose or hyperkalemic case. But I think we know when to use drugs and when not to use drugs. And when you have that information, just reaching for saline every time seems a little bit odd. The other thing I'll say is, if you have a problem giving a drug with lactated ringers through one little 22-gauge IV, I don't know how you resuscitate people in Utah, but that's Taco Bell weak sauce in Texas, bro. I mean, we get big IVs. As we're talking about, Ashley's talking, we get multiple IVs. We get large girth IVs in Texas, and maybe central lines so we can get multiple drugs. So if you got to take a time out in order to push some Rocephin in between your lactated ringers, it ain't the problem with the drugs. It's a problem with your resuscitation, man. So that's my argument. In the end, I think we can agree that, yes, we need to be nuanced in our approach to use these drugs, but reaching for saline every time is fraught with difficulties. And I think we're going to see more evidence coming out that we're leaning towards using lactated ringers, especially for the large resuscitations on patients that have acidosis and sepsis and DKA. So, any last thoughts, Rob?
Yeah, Scott, you make some good points. My concern is that it's really hard to find septic patients all of the time. They don't come in saying, look at me, I'm septic. So when my undifferentiated hypertensive patient comes in, I don't know if they've got a bad brain. I don't know if they've got a TCA overdose. I don't know if there's some other issue going on. So I think I can at least give a first liter of saline while we're working out what's going on to be certain that I'm not hurting my patients. And then I'll give in, and if the patient for sure has sepsis, then I'll switch to your LR. But other than that, I'm still going to stick with not making my nurses angry.
Well, I think we could agree to disagree. That's
All right.
good.
Sounds good.
No,
we should hug.
All right, so while we are getting our next two pro-cons up and switching mics, we have time for maybe one or maybe two questions for these guys. Anyone have any questions on balanced versus not balanced, unbalanced?
So speaking to your point of in your undifferentiated patient starting out with a liter of NS, so I've tried to implement that in my practice as well. With all these coming out, I was like, man, am I behind the times? When am I not doing this? It's nice to know that no, I'm not. It doesn't mean a whole lot. But anyway, I find the most difficult thing is to get a nurse to grab one bag of NS and then that second bag be LR. That is beyond getting a enema in the emergency department. Difficult. Is there any recommendation have you found to getting this done? Like, I don't know, bright yellow signs, cookies, pizza, whatever. I don't know what I can do further.
This is, initially with the speed of the FOMED movement with multiple changes to our practice coming, I've been able to gradually wear my nurses down by change in my practice number 10. They've gone from saying, explain everything about this to, okay, explain it a little bit, to now me saying, hey, like after that saline, can we hang LR? And I'll start to explain it and say, don't worry, I'll just do it. So you can eventually wear some of the clinicians you work with down by making changes or having an evidence-based change. Intermountain Healthcare is making a wholesale switch within our electronic health record to make it easier to order LR than saline, so that the preferred IV fluid now will be LR. They're actually studying across basically all of Utah, so it's a bunch of white people, so it's not really, doesn't really translate well to the rest of America. But for white bread Utah, we will at least maybe have a bigger population-based answer of, does this change from wholesale saline to wholesale LR actually provide some weird magical death benefit, or does it do nothing?
All right, guys, thank you very much. Pictures. For any of your sexual complaints of sexual inappropriateness, that's Hillary Fairbrother. If you can give your Twitter handle later, that'd be great too.